I'd like to extend a very warm welcome to all of you who are listening to our webinar this evening. My name is Linda Henderson, and I'm a member of the board of Thyroid Federation International. TFI has hosted several webinars that we feel of interest to thyroid patients throughout the world, and also is interest to members in the medical field as well as patients. Ashok Basin, president of TFI, is also joining us as well this evening. Hi, Ashok. This evening, and I realize that perhaps it's not evening where you are, but morning or afternoon or even after, I have the pleasure of introducing two well-known specialists from Italy to speak on thermal ablation of thyroid nodules, Dr. Enrico Papini and Dr. Giovanni Mauri. Dr. Papini is from the Endocrinology and Metabolism Department at the Ospedale Regina Apostolorum in Rome, and Dr. Mauri is from the Division of Interventional Radiology at the European Institute of Oncology in Milan. You probably are aware, if you're listening to this webinar, that benign thyroid nodules are very frequent and widespread in the general population. Many patients find that they have these nodules by accident during imaging tests. In the last 2 decades, several minimally invasive treatments have been proposed, aimed at the ambulatory treatment of symptomatic nodules without the need for general anesthesia and with minimal risk of damage to the skin and cervical tissues. This evening, our speakers will explain thermal ablation techniques, which represent innovative, promising, and revolutionary procedures in the field of modern medicine. They'll update us on the notions of thermal ablation, thus aiding doctors and patients in the increasingly difficult creation of a personalized, conscious, and adequate path for treatment. Just a few things that I'd like you to note. Should you have any questions, please submit these in the chat box on the right-hand side of the screen. You'll see it says chat. In the meantime, I have some preliminary questions, but I'm sure that the listeners would like to know. But let's see if these will be answered in the presentations. Some of these questions are: do I need general anesthesia for thermal ablation? Do I need hospitalization? Can I go to work after TA and after how many days? Will I need antibiotics? Will I need painkillers? And for how long? Thank you for your attention. Right now, I would like to start the webinar, and I'd like to introduce Dr. Giovanni Mauri. Thank you, Giovanni. Giovanni, I think you're on mute.
Linda. Okay, I'm sorry. Thank you, Linda. Thank you for this kind invitation. And it's a great pleasure for me to be here today, this evening. I am an interventional radiologist, so I'm doing ablation of different kind of organs. And today I will talk to you about ablation of thyroid. As Linda already told you in her introduction, thyroid nodules are very, very common in the general population, reaching around half of the female population of over 70 years. And thyroid nodules sometimes are detected by clinical appearance, but most often are detected nowadays by ultrasound, because with ultrasound we can find also very, very small thyroid nodules. Benign thyroid nodules generally, let's say that thyroid nodules are, for the large majority of cases, benign, but even if benign, they can require treatment in some cases. Fortunately, not in the majority of cases, but in some cases, treatment might be necessary. And when treatment is necessary for a benign thyroid nodule? Mainly when it grows and determines symptoms that might be of compression in the neck, or also only for aesthetic concerns, because thyroid nodule can become very well visible. Also, in some cases, hyperfunction of the thyroid might occur, and also in this case, a treatment might be required. Historically, the standard treatment has been surgical removal of the whole gland, or more recently, and in cases where only one lobe is involved by nodule, of only half of the thyroid. Even in very experienced hands and center with large numbers, surgery is still burdened by a variable amount of complications, which are generally minor, but might be not negligible. And also, hypothyroidism can occur in a large percentage of cases after even the removal of half of the thyroid. And also, it's a cost procedure. So, which is the reason to apply thermal ablation to benign thyroid nodule? The rationale is that with ablation, we achieve a progressive nodule shrinkage, so a reduction of the nodule volume, which not disappear, but reduces in size. And this reduction can determine a resolution of the symptom, because we should remember that it is a benign condition, and we want to treat the symptom of the patient, not the nodule. Some surgeon may say that without surgery, we are not going to remove the nodule, but we do not want to remove the nodule. We do want only to treat the symptom of the patient. The reduction of the thyroid nodules occur because we know very well from large experiences in the liver, in the kidney, that when we are able to reach a temperature higher than 60 degrees, we can achieve a cell death. This is applied for the treatment of tumors, but is also the basic principle to achieve shrinkage of the nodule. So what we want to obtain is to increase the temperature of the cells into the thyroid nodule up until 6 degrees in order to achieve cell death and subsequent cell absorption. How do we perform ablation? Ablation is performed under local anesthesia. In some cases, it might be necessary to apply also mild sedation, but not in all cases, and this is something that we can decide to use on a patient-by-patient basis. The whole procedure is guided by ultrasound, so we can follow each single step of the procedure with high precision by looking at the needle and the thyroid nodule with real-time ultrasound. Generally, for a medium-sized nodule, the whole procedure from the beginning to the exit of the patient to the operatory room is no more than half an hour, 45 minutes. And immediately after, there is no pain or a very limited pain, which can be very well managed by a few amount of painkillers. The patient lay on the table with hyperextended neck. It's important to find a very comfortable position for the patient and also for the operator. There are two main techniques at the present for performing ablation of thyroid nodules. The first one is laser ablation. With this technique, it is possible to use very, very small needles. Let's say as small as the one used for fine needle aspiration. Up to 4 needles can be infused nodule and released at the at that position while optical fibers are inserted into the needles and energy is applied. The fibers are inserted into the deeper part of the nodule, an ablation is performed, and then the fibers are retracted with a pullback technique more superficial area. So it is not necessary to puncture multiple times the nodule. With the other technique, which is radiofrequency ablation, the needles are a little bit larger, but only one needle is inserted into the thyroid. And that needle is moved several times, and multiple small ablations are performed one after the other in the so-called moving shot technique. In this way, again, the thyroid nodule is punctured only once, but we are moving several times the needle inside the neck of the patient. Now, we are going to show you a very quick and brief video to more clearly demonstrate how this kind of treatment works. So, with the patient laying on the table with hyperextended neck, under ultrasound guidance, a small needle is inserted into the nodule, the benign nodule that you want to treat. Thermal energy is applied before in one region, then coming out of the thyroid to a different region. This can be repeated several times, so this is just an example. And what happens? After some months, the nodule reduces its size, and this correlates with a reduction in the symptoms of. This is a very simple technique. This can be performed easily by experienced operator, and with local anesthesia, the patient do not feel almost anything. So this was the presentation regarding the basic aspect of the technique. And with this, I thank and say thank you. And I'm happy to introduce my good friend and colleague, Enrico Papini, who was one of the first in the world to apply these techniques in the treatment of thyroid nodule. So, please, Enrico, you can take over with your presentation. And thank you all for the attention.
Good morning to all of you, or good afternoon. I don't know exactly where you are. And many thanks, Giovanni, because this presentation was quite clear. And I suppose that for persons who were not acquainted with these procedures, now they have a very good idea of the technique and the possible results. And so now we have just to talk about a series of considerations that may be of use. Next slide. Well, as Giovanni told us, surgery is, roughly speaking, a quite safe procedure, but we have also some, undesired effects. One, especially for women, is the presence of a scar in the neck. And for some persons, it can be quite nasty. And moreover, in most cases, a lifelong substitution therapy with levothyroxine is needed. And in a small number of cases, we can also have some, complication that, of course, is not severe, but even these may be nasty. Next. And for this reason, the European Thyroid Association performed a series of studies. The first one was a survey for understanding what is the diffusion of this technique in the different European countries. Then we performed a guideline for good clinical practice for the use of thermal ablation for benign lesion. And then, together with Giovanni, it was the first author, for the use even for malignant thyroid lesions. But today, we are going to talk only about the use in benign conditions. Next. Well, what is most important is that one size does not fit all. That is, we have minimally invasive techniques. They are an important step forward, but we must remember that a new technique is not something that will in some way shadow all the previous procedures. And so now we must clearly define when this procedure should be used and when should not. Next. Well, I will try to show you some clinical cases because it's, in my opinion, the best way to understand when we should use one technique, when another, or when we must use surgery as usual. And so this is a young woman, 36 years, and one morning when she woke up, she felt pain in the right cervical region, and she appreciated a lump in the neck. And it was quite sudden because the night before she didn't have anything. And so she performed an ultrasound examination that demonstrated a cystic lesion just around 3 centimeters in the greatest diameter. She performed a fine needle aspiration that drained the bloody content of the cyst, but, well, 1 week after the drainage, she had a relapse of the lump, and so she had the problem what to do next. In this case, the best option is still ethanol injection, because ethanol allows, with a minimal cost, with a very rapid procedure, and without any harm for the patient, to induce a sclerosis of the cyst and the decrease of the volume of the cyst. Next. You can see here the procedure. The patient is placed without any, well, drug, but just with a small local anesthesia, with the head hyperextended, as in a case of a thermal ablation. A needle is put inside the cyst. The fluid, in a few seconds, is nearly completely drained, and next, after the drainage of the fluid with the same needle inside, is injected an amount of ethanol that is up to 50% of the fluid that was removed, and the ethanol may be left inside the nodule, and within a few months you'll have a progressive decrease of the size of the cystic lesion. In some cases, if the fluid is in a large amount and the cyst is very large, you may need a second treatment, but anyway, this is completely an outpatient clinic condition, and the patient can perform the usual activities of his life after the treatment. Next. And this is, well, an example. As you can see, you have a progressive reduction month after month until a nearly complete disappearance of the cystic lesion. But as you can see in the lower part of the slide, if you have a mixed nodule, that is a nodule with a fluid content, but also with a solid part, ethanol cannot destroy the solid tissue that is present in the nodule. And in this case, we should probably better use thermal ablation according to the techniques that Giovanni showed you before. Next. Next slide. And just one consideration. We must always take care of the benign nature of our nodule before performing a minimally invasive treatment, because as you can see in this young, pretty girl, 17 years old, apparently she had a cyst, but if you look carefully, in the center of the cyst, there is a solid lump, and the solid lump was sampled by fine needle aspiration and was a cystic papillary cancer. And so remember, you always need a confirmed benign report from fine needle aspiration from cytology before performing any kind of minimally invasive procedure. Of course, in this case, surgery is the best option for the patient. Next. And here is a case that is perfect for thermal ablation. She is Joan, is a very busy woman. She is 56, and in 2012, she had a 3 centimeter nodule in the right thyroid lobe. And this nodule went growing very slowly, but along 8 years, the nodule became 4 centimeters. And now you can look at the neck and see that there is a lump, not a giant lump, but you can anyway spot it. And the lady is, well, feeling some discomfort in the neck. She performed a fine needle aspiration, and the cytology was definitely benign. This is the perfect case for thermal ablation treatment. Next. And so you can see that we have, of course, different nodules. That is, yes, the size is very important. The fluid content is very important for deciding if performing thermal ablation or performing ethanol injection or performing surgery. But we have also some more, well, subtle characters that the operators must consider. For instance, if we have a mixed nodule like the one in the upper left of the slide, this kind of nodule will go magnificently with the thermal ablation. On the upper right side, you have a completely solid nodule. You'll have good results also for this nodule, but probably they will be less impressive than for a mixed nodule like the one on the left. We call it spongiform. And also, the vascular supply may be important because for some techniques, the presence of a relevant vascularization may drain some of the energy of the head outside the area of the nodule. And so probably you will need more energy and some more time for obtaining the same results. And last, the stiffness of the nodule may be important because more stiff, more of the fibrotic component, and probably less the result of the treatment. But anyway, these are variables that must be investigated and considered by the operator and not by the patient. Next. And just to finish, this is Daniel. He is quite young, and he, well, was not so concerned about his health. And so he knew that he had some problem with his thyroid gland, but he didn't do anything until he started to experience cervical discomfort with some problem in swallowing, and thyroid ultrasound demonstrated a very large nodule, inhomogeneous in the right lobe. And next, in this case, we can use thermal ablation, but in this case, due to the young age, the huge dimension of the nodule, we could also consider the possibility of surgery, because in this case, you could have the need of repeated treatment. And so this should be a choice that you offer to the patient. Next. And so just to conclude our conversation, ethanol injection is the best treatment for cystic lesion that relapse after the drainage of the fluid content. Next. Thermal ablation, that is laser, radiofrequency, or even microwaves, is indicated for patients with a nodule that is certainly benign, because the patient had a confirmatory fine needle aspiration that showed a benign condition, that is starting to complain of symptoms, or, is concerned about the lump in the neck. And so we should use this procedure for changing the natural history of those nodules that keep growing over time. Next. And of course, if the nodule is inside a diffuse goiter, is a large nodule, probably surgery remain the mainstay of the treatment, unless we have some anesthesiological risk that suggests us that it's best to perform anyway a treatment with thermal ablation. Next. And laser and radiofrequency are widely used techniques, and there is a robust evidence that demonstrate their efficacy and safety. Next, we know that the reduction of the nodule is well, quite satisfactory, ranges from at least 50 up to 90 or 95% after 1 year. And of course, the outcomes depend by the volume, by the structure, by the liquid component, and of course also by the amount of energy that is delivered to the lesion. Next. And we know that this reduction in the size usually remains stable for many years. Just in a minority of cases that range from 10 to 20%, we have a partial initial regrowth of the nodule after 5 years, and in that case, we can repeat a treatment with a thermal ablation with equally effective results. Next. And so, of course, this is a bit complicated, but anyway, we are ready for answering to all the questions that can better clarify this issue. Many thanks.
Thank you so very, very much, Enrico and Giovanni. I think those were excellent presentations. The questions that I had in the beginning, I think, were answered. One thing was, do I need general anesthesia for thermal ablation? I read that no, that's not necessary. Do I need hospitalization? Correct me, please, if I'm wrong. No. Can I go to work after TA and after how many days? Well, I suppose that depends on the person, but it seems that it's fairly quick. Will I need antibiotics? Can you answer that?
No, generally speaking, no.
Okay, will I need painkillers?
If you perform the treatment under sterile condition as usual, you don't need antibiotics, or maybe, but we can ask also Giovanni about this, just a single shot of antibiotic just before performing the procedure. Giovanni, what is your...
I do not deliver antibiotics afterwards. And
yes.
About painkillers, generally is not necessary, or eventually just for a couple of days for mild discomfort in the neck.
Painkiller, okay. I have a question from a doctor in Italy, and the question is, by using thermal ablation, is the percentage of iatrogenic damage to the laryngeal nerve, is it less, equal, or greater to the surgical technique?
Absolutely less.
Less? Okay.
No risk of the risk of damage is extremely low if the technique is done properly. I do not remember any damage of the nerve.
Okay, good.
And most important, you must remember that there is a well-defined danger zone that all the operators can recognize, and they should avoid this danger triangle that is well-defined. And so, well, in some way, it's a mistake if you induce a damage. And moreover, generally speaking, even if you induce a damage, after 1 or 2 months, you have the recovery of the function, because the laryngeal nerve generally is just, well, injured, but not cut. And so it you have a 1 or 2 months dystonia, but you nearly always have a complete recovery.
Fantastic, thank you. I think this could be a question, but I'm pretty sure that Enrico answered it. How can I be sure that the nodule is really benign and not a cancer? Am I at risk?
Well, I can tell you this. When you perform a fine needle aspiration biopsy and the report is benign cytology, you have a certainty that is about 92% that the nodule is really benign. If you perform after a few weeks a second fine needle aspiration, and again the report tells benign, well, the risk of a malignant condition is under 1%. And so two confirmatory fine needle are enough to rule out with nearly certainty the risk of a malignant condition.
Perfect. I'll ask one more question because then our time is running short. And I think that I can almost answer this myself. After treatment, does the nodule disappear, or this is what you were saying, Enrico, or do I need ultrasounds for the following years? And I noticed in your presentation that you said you can repeat the ultrasound after 5 years, if I'm not mistaken. And
well, I would like to have the opinion also of Giovanni, but generally speaking, we perform serial ultrasound examination. That is, we perform ultrasound examination after 6 months and then after 1 year in order to, well, define the decrease of the size of the nodule. And Giovanni, what is your approach?
Yes, it's similar. Sometimes I also look at the patient after a couple of months, because at that time the patient starts to feel really better, and I want to have an initial idea. But generally afterward, patients are controlled as they do generally before every 1 to 2 years with ultrasound, not more often.
I have a question from a person from Turkey, and he says, "Hi, I am an interventional radiologist from Turkey. If we are planning to TA to 2 nodules, how long should we wait between the 2 operations?"
Giovanni?
Okay, so actually I understand our 2 nodules into 2 different lobes of the thyroids. Of course, generally the indication is for uninodular thyroid, but if you want to treat this patient with 2 thermal ablation, I would wait at least, let's say, 6 months as an ideal. So we can see how the first is reduced, how the patient heal, and we can proceed. The patient has a lot of symptoms. From a technical point of view, also the months after you can perform the treatment. So it's more according patient to patient. I would suggest to wait at least, let's say, 6 months.
Okay, I think that answers Nihan's question. I think we're done with the questions, but I would like to hand over to Ashok right now. And Ashok is, like I said, is the president of TFI. And Ashok, it's up to you now. Thank you so much.
Thank you, Linda. And I would like to thank all the attendees who registered to attend the webinar. Without them, we have without them, we cannot attain what we want to in terms of awareness, in terms of education. So thank you all for attending. My special thanks for Professor Enrico Papini and Giovanni Mauri from Milan and from Rome, respectively. So, without their precious time that they gave away from their families and their personal time that they gave us, this would not have been possible. Thank you so much, Professor Enrico and Giovanni, for putting this up. Of course, this will be available on our social network site of TFI, which we will keep you informed. And I would like to also thank Port Innoveli Group for hosting this webinar, and to our very own Linda Henderson for organizing this webinar. So thank you all very much, and this will be available in our social media and on our websites at TFI. Thank you once again for attending, and thanks you all for your precious time today. Thank you, and bye.
Thank you, Ashok. Thank you again, Giovanni, and thank you, Enrico. And hopefully we'll be able to organize another webinar with you both, because you're both very specialized in the field, and perhaps we can discuss something in the future next year as well. So thank you again, and I wish everybody a good evening or good afternoon or good night or whatever. And thanks for participating. Bye.
Thank you
Many
very much.
thanks. Many
Bye-bye.
thanks to you.
Thank
Bye.
you.
Bye.